Hi, my name is Nicholas Hatcher, and this lecture will be on mechanical ventilation. Mechanical ventilation aims to replace the bellows function of the lungs, which is inspiration and expiration, using preset values adjusting the rate, volume, pressure, and oxygen that the lungs would normally maintain in order to achieve a dynamic equilibrium, which is a changing balance, of gas exchange. I would like to begin with a review of relevant physiology associated with ventilation. Ventilation is determined by the following factors: inspiration, expiration, air pressure variance, air resistance, compliance, and lung volumes and capacities. Let's look into each of these components with a little bit more detail. During inspiration, contraction of the diaphragm moves this chamber floor downward, and contraction of the external intercostal muscles increases the space in this chamber. Lowered intrathoracic pressure causes air to enter the airways and inflate the lungs. This produces a negative pressure environment. Inspiration is normally 1/3 of the respiratory cycle. During expiration, the diaphragm relaxes and the intrathoracic pressure increases. This increased pressure pushes air out of the lungs and produces a positive pressure in the lungs. Expiration requires elastic recoil, i.e. compliance, of the lungs. Expiration is normally 2/3 of the respiratory cycle. Airway resistance is determined primarily by the size or radius of the airway through which the air is flowing. With a decreased size or radius, there's an increase in resistance. With increased resistance, greater than normal respiratory effort is required to achieve normal levels of ventilation. Air follows a concentration gradient from an area of high pressure to an area of low pressure. Inspiration results in a pressure below atmospheric pressure. This results in air being sucked in. Expiration leads to a pressure above atmospheric pressure, leading to air flowing out of the lungs. A relationship exists between pressure and volume. Pressure and volume are inversely proportional. Therefore, when you have an increase in pressure, you have a decrease in volume. And when you have a decrease in pressure, you'll have an increase in volume. As you could imagine, exerting pressure on the lung would reduce the amount of volume that it can contain. On the other hand, a reduction in pressure would allow the lung to expand, thereby it could contain more volume. Compliance refers to the elasticity and expandability of the lungs and thoracic structures. This allows the lung volume to increase when there's a difference in pressure between the atmosphere and the thoracic cavity. Things that contribute to compliance include the surface tension of the alveoli, related to surfactant, and the connective tissue of the lungs. Compliance is equal to a change in volume divided by a change in pressure. So based on compliance, you will get a certain pressure. With a decreased compliance, you'll have an increase in pressure. With an increase in compliance, you'll have a decrease in pressure. It's important to note that compliance does not refer to the airways themselves. It refers to the lung tissue and the alveoli. The final physiological principle I would like to discuss is lung volumes and capacities. Here I'll draw a graph to show the relationship between volumes and capacities. Over on this axis, the numbers shown are milliliters of lung volume. Inspiratory capacity, or IC, is the volume of air that can be inspired after a normal expiration. Tidal volume, or VT, is the air volume of each breath. Total lung capacity, or TLC, is the volume of air in the lungs after a maximum inspiration. Residual volume, or RV, is the volume of air remaining in the lungs after a maximum exhalation. Expiratory reserve volume is the maximum volume that is exhaled after a normal exhalation. Inspiratory reserve volume is the maximum volume that is inhaled after a normal inhalation. Vital capacity, or VC, is the maximum volume of air exhaled after a maximum inspiration. And finally, functional residual capacity, or FRC, is the volume of air remaining in the lungs after a normal expiration. I would like to review how ABGs are typically written out, and also the normal values. So usually you'll see them written like this. First you'll see pH, and then PCO2, then PO2, and finally bicarb. Your normal value for pH is 7.35 to 7.45. Your normal value for PCO2 is 35 to 45 millimeters of mercury. Your normal value for PO2 is 80 to 100 millimeters of mercury. And a normal bicarb is 22 to 26 milliequivalents per liter. Now let's discuss the indications for mechanical ventilation. The first indication is an alveolar filling process. Conditions that fall into this category include pneumonitis due to infection or aspiration, pulmonary edema or ARDS due to infection, inhalation injury, near drowning, transfusion, contusion, or high altitude, pulmonary hemorrhage, tumor, and also fluid volume overload of any cause. Essentially, the problem here is altered alveolo-capillary distance leading to a change and impairment in diffusion. The second indication is pulmonary vascular disease. The most common disease falling into this category is a pulmonary embolism. The third indication is airway obstruction. This can be due to a tumor, laryngeal angioedema, stenosis, COPD, or asthma. The fourth indication is hypoventilation. This can be broken down into three different groups of diseases. The first is a decreased drive. This primarily refers to the central nervous system and occurs in situations such as anesthesia or drug overdoses. Neuromuscular dysfunction refers to the peripheral nervous system and musculoskeletal system. Conditions that fall into this category include ALS, Guillain-Barré syndrome, myasthenia gravis, tetanus, and muscular dystrophy. The third group of disorders are chest wall and pleural disease. Diseases that fall into this group include kyphoscoliosis, massive effusions, and pneumothorax. The fifth indication is increased ventilatory demand that occurs in sepsis, shock, or severe metabolic acidosis. Many of these conditions lead to impaired oxygen and carbon dioxide exchange, resulting in acute respiratory acidosis and hypoxemia, and ultimately leading to respiratory failure. Acute respiratory acidosis presents with a PCO2 of greater than 50 and a pH of less than 7.25. Hypoxemia presents as a PO2 of less than 55. The objectives of mechanical ventilation are to reverse hypoxemia, reverse acute respiratory acidosis, relieve respiratory distress, prevent or reverse atelectasis, reverse ventilatory muscle fatigue, permit sedation or neuromuscular blockade, and finally decrease systemic or myocardial oxygen consumption. Let's compare negative and positive pressure ventilation to forms of mechanical ventilation. You remember that the lung normally converts to a negative pressure environment, leading to air sucking into the lungs. When you mimic negative pressure ventilation, no artificial airway is required. An example of negative pressure ventilation is the iron lung. In positive pressure ventilation, by use of a mechanical ventilator, an endotracheal tube, or ETT, is required. The forcing of air into the lungs provides a positive pressure environment and forces the lungs to expand. The biggest difference between these two is that in negative pressure ventilation, air is sucked in, whereas in positive pressure ventilation, air is pushed or forced in. There are a few notable pressure techniques. One of the most notable is positive end-expiratory pressure, or PEEP. In using PEEP, pressure is maintained above atmospheric pressure at end expiration. Normally, when you inhale, your alveoli expand. When you exhale, your alveoli collapse or close down. With the addition of PEEP, the alveoli remain open during inspiration and expiration. The net result of this is an increase in functional residual capacity, or FRC. The benefits of an increase in FRC include an increased surface area, prevention of collapse, a decrease in interpulmonary shunting, improved compliance, and improved oxygenation. These mechanisms lead to some really good benefits of using PEEP. Number one, because there's an increased surface area for diffusion and a decrease in shunting, lower FiO2 is needed, therefore there's a reduced risk of oxygen toxicity. Next, positive intra-airway pressure may be helpful in decreasing transudation of fluid from the pulmonary capillaries. This is especially beneficial in conditions where capillary pressure is increased, such as with CHF. Finally, an increase in lung compliance results in a decrease in the work of breathing. Continuous positive airway pressure, or CPAP, assists the spontaneously breathing patient to improve oxygenation by increasing end-expiratory pressure in the lungs throughout the respiratory cycle. This functions much like PEEP and may be delivered via vent circuitry or through separate circuitry. It's indicated for patients unable to maintain adequate tidal volumes and have a pathology preventing the maintenance of adequate tissue oxygenation, or patients who have obstructive sleep apnea. CPAP has the same benefits, hazards, and precautions as PEEP. The mean airway pressure may be lower due to a lack of ventilator breaths. This results in a decreased risk of barotrauma and less impedance of venous return. We've discussed many of the benefits of positive pressure, but there are also consequences. Blood follows a concentration gradient from high pressure to low pressure. Blood returns to the right atrium via the superior and inferior vena cava. Because of the increased intrathoracic pressure induced by positive pressure in general, PEEP or CPAP, there's a decrease in venous return. A decrease in venous return results in a decrease in cardiac output and oxygen delivery to tissues. This is especially true in the hypovolemic patient. A drop in your cardiac output also reduces your blood pressure. Other effects of a decreased venous return include a decrease in renal perfusion, increased intracranial pressure due to impaired cerebral venous outflow, and hepatic congestion. Before we get into the modes of mechanical ventilation, I would like to discuss some underlying principles. The following are variables that control ventilation and oxygenation. The first is rate. This is often set on the ventilator to 12 to 16 breaths per minute. Remember that an increase in rate will lead to an increase in ventilation, but also an increase in dead space, which is approximately 150 milliliters with each breath. The second variable is tidal volume. This is the volume of gas with each breath. This is often set to 6 to 8 milliliters per kilogram of ideal body weight, which usually ends up being between 500 and 600 milliliters. An increase in tidal volume leads to an increase in ventilation with less increase in dead space compared to rate. The third variable is flow rate. The peak flow rate is the maximum flow delivered during inspiration. This is often 60 or more liters per minute. The fourth variable is the fraction of inspired oxygen concentration, or FiO2. You want to aim for the lowest possible FiO2 necessary to meet oxygen goals, which should be a PaO2 of greater than 60 and an oxygen saturation of greater than 90%. The higher the FiO2, the higher the PaO2 and SpO2 will be. The fifth variable is ventilator dead space. This refers to the circuitry or the ventilator tubing. This is often calibrated. The sixth variable is positive end-expiratory pressure or PEEP. This is often set to anywhere from 5 to 20 centimeters of water. To help differentiate a bit between PEEP and CPAP, PEEP is used when a rate is set, and CPAP is used when there is no set rate. Now we will discuss ventilator modes. There are two broad categories of ventilator modes, the first being volume modes, and the second is pressure modes. The two volume modes I'll discuss is assist control, or AC, and spontaneous intermittent mechanical ventilation, or SIMV. The pressure modes I'll discuss include pressure control and pressure support. In assist control, or AC, you set the tidal volume as well as the rate. The patient triggers the vent. Inspiratory effort produces a negative pressure. The vent senses this pressure and delivers a preset volume. If the patient does not initiate spontaneous breathing, or the breath is too weak, then the vent will maintain a minimum respiratory rate with a set volume. Remember that tidal volume is affected by compliance. Indications for assist control include a patient who's breathing spontaneously but has the potential to lose their respiratory drive or musculoskeletal control. In spontaneous intermittent mandatory ventilation, or SIMV, the patient is able to breathe at their own rate and volume spontaneously through the ventilator. Periodically, at a prescribed time, a mandatory breath is delivered. This is often synchronized with inspiratory effort. This ensures that the patient gets a predetermined number of breaths at a selected tidal volume. SIMV is indicated for patients breathing spontaneously, but at a tidal volume or rate less than adequate for their needs. This allows the patient to do some of the work. In pressure control, the upper airway pressure is set, respiratory rate is set, and the tidal volume varies related to compliance. If you have a set pressure but compliance is low, then your volume will be low. This relates back to that equation that I showed you, C equals change of volume over change in pressure. The ventilator will give a set pressure level whether the patient triggers or a mandatory breath is delivered. If lung compliance is low and the volume is low, then the pressure will trigger an increase in volume. A good way to remember this mode is that it's essentially the opposite of assist control. Pressure support augments inspiration in a spontaneously breathing patient. An upper or inspiratory positive pressure level is adjusted to provide adequate tidal volume for each patient-triggered breath. An increase in pressure leads to a bigger breath. Pressure support is like CPAP or PEEP, but only on inhalation. Pressure support is also like assist control, but instead of a certain volume, you get a certain pressure. This is a popular weaning mode. Nursing care for the patient receiving mechanical ventilation includes the following. 1. Monitor for complications. 2. Provide routine care. 3. Assist with the weaning process. And 4. Once weaning is successful, extubate and provide an alternative means of oxygenation. While caring for the patient receiving mechanical ventilation, monitor the patient for the following potential complications: airway aspiration, decreased secretion clearance, ventilator-associated pneumonia, tracheal damage, laryngeal edema, impaired gas exchange, which can present as an acid-base disturbance or oxygen toxicity, ineffective breathing pattern, endotracheal tube kinking, cuff failure, mainstem intubation, sinusitis, pulmonary infection, acute lung injury, which can be due to either barotrauma or excessive pressure, or volutrauma, which is excessive volume. Barotrauma can result in pneumothorax and subcutaneous emphysema. Also monitor for a decreased cardiac output due to the increase in intrathoracic pressure. A decrease in cardiac output can result in a decrease in blood pressure and impaired renal perfusion. Refer back to the slide where we discussed the consequences of positive pressure for more information on this. Atelectasis is another complication that can occur, and this essentially happens when there's derecruitment of alveoli. Altered GI function can present as stress ulcers, gastric distension, or paralytic ileus. An alteration in cognitive or perceptual status can be an indication of cerebral hypoxia, but could also simply be a side effect of sedation. Routine care for the patient on the mechanical ventilator includes the following. Couple the patient's airway to the vent. Make sure all connections are secure, and prevent ventilator tubing from pulling on the artificial airway, possibly resulting in tube dislodgement or tracheal damage. Your assessment of the patient on the vent should include the following. Assess respiratory effort and breath sounds every 2 hours in all lobes bilaterally. Determine whether breath sounds are present or absent, normal or abnormal, and whether a change has occurred. Auscultation of the chest is a means of assessing airway patency and ventilatory distribution. It also confirms proper placement of the ET tube or tracheostomy tube. A change in respiratory status may be evidenced by a change in the ABGs, pulse oximetry, spontaneous respiratory rate, use of accessory muscles, breathing sounds, and vital signs. Monitor the patient's heart rate and blood pressure. Intra-arterial pressure monitoring may be carried out for these patients. Arterial catheterization for intra-arterial pressure monitoring also provides access for ABG samples. The use of a pulmonary artery catheter to monitor pulmonary capillary wedge pressure, or PCWP, mixed venous oxygen saturation, or SVO2, and cardiac output, or CO, may be used. Intermittent and continuous positive pressure ventilation may increase pulmonary artery pressures and decrease cardiac output. Check for secure stabilization of the artificial airway. This will reduce the risk of inadvertent extubation. In positioning the patient, it's important to turn them side to side at least every 2 hours, or more frequently. Lateral turns are desirable from right semi-prone to left semi-prone. Sitting the patient upright at regular intervals increases lung compliance. Proning may be considered to improve oxygenation. This may be difficult without a proning bed, but proning has been shown to have some beneficial effects for the improvement of oxygenation in certain populations, such as patients with ARDS. Considering kinetic therapy as an early intervention has been shown to improve outcomes. Repositioning in general may improve secretion clearance and reduce atelectasis. Carry out passive range of motion exercises of all extremities for patients unable to do so. This will prevent contractures. Humidity improves secretion mobilization. Typically, respiratory therapy manages humidification on a ventilator. However, it's important to empty the water that condenses in the delivery and exhalation tubing into a separate receptacle. Always wash your hands before and after emptying fluid from the vent circuitry. Water condensing in the inspiratory tubing may cause increased resistance to gas flow. This may result in increased peak airway pressures. Also, warm, moist tubing is a perfect breeding ground for bacteria. If this water is allowed to enter the humidifier, bacteria may be aerosolized in the lungs. Emptying the tubing also prevents the introduction of water into the patient's airways. Try to remember this, especially when you're turning a patient who's on the vent. Check and be sure that there's not water condensed that may enter the patient's airway as you're turning them. Mouth care should be provided every 2 hours, and at this time you should assess for the development of pressure areas from the ET tube. This is not only for comfort, but decreases the risk of ventilator-acquired pneumonia and infection. Regarding the ET tube tape, it should be reapplied, and the ET tube should be repositioned every 24 hours or PRN. Patients on the vent should also be monitored for systemic signs and symptoms of pulmonary infection. These can include pulmonary physical exam findings, increased heart rate, increased temperature, and increased white blood cells. The risk of infection is increased with an artificial airway. Another part of the routine care of the mechanically ventilated patient is to implement a ventilator bundle protocol. These are used to prevent ventilator-associated complications. A way to remember what ventilator bundles usually consist of is by remembering the mnemonic FASTHUGS. F stands for feeding and fluids. It's important to report the intake and output precisely and obtain an accurate daily weight to monitor fluid balance. Positive fluid balance resulting in increased body weight and interstitial pulmonary edema is a frequent problem in patients requiring mechanical ventilation. Prevention requires early recognition of fluid accumulation. An average adult who is dependent on parenteral nutrition can be expected to lose half a pound or 0.25 kilograms per day. Therefore, constant body weight indicates fluid retention. Another method of monitoring nutritional status is to assess a prealbumin level. A nutritional consult may be required with prolonged therapy. A stands for analgesia. While patients on the ventilator can't verbally express their pain, there are tools available that will allow the nurse to assess the patient's pain. Two of these are the Behavioral Pain Tool, or BPS, and the Critical Care Pain Observation Tool, or CPOT. S stands for sedation and sedation vacation or interruption. Evaluate the patient's need for sedation or muscle relaxants. Sedatives may be prescribed to decrease anxiety or to relax the patient to prevent competing with the vent. At times, pharmacologically induced paralysis may be necessary to permit mechanical ventilation. You want to ensure that you're aiming for calm and alert, using appropriate sedation scales for assessment. Sedation vacations enhance your assessment of the patient and also give you an opportunity to assess the readiness to extubate. T stands for thromboembolic prophylaxis. Because the patient is sedentary for the time being, their risk of VTE increases. Therefore, something like Lovenox or SCDs may be indicated. H stands for head of bed elevation. You want to always ensure that the head of bed on a mechanically ventilated patient is at 30 to 45 degrees. U stands for ulcer prophylaxis. Depending on the provider, Pepcid or Protonix may be ordered. Mechanically ventilated patients are at risk for developing stress ulcers, resulting in occult or frank GI bleeding. It's important to test all stools and gastric drainage for occult blood, per protocol. G stands for glucose or glycemic control. This is especially important in the diabetic patient. Often when mechanical ventilation is initiated, tube feedings are not initiated at that time. Be sure you're checking the patient's blood glucose and contact the prescriber for appropriate management. S stands for suctioning and skin care. Assess the need for suctioning at least every 2 hours. Patients with artificial airways are unable to clear secretions and stimulate the cough reflex. Increased secretions increase the peak airway pressure. When secretions can be seen or sounds resulting from secretions are heard with or without the use of a stethoscope, this is when it's important to suction. Also after chest physiotherapy and after bronchodilator treatments. Turning every 2 hours is one method of addressing skin care, but also monitor for incontinence episode and treat breakdown appropriately. Provide psychological support and assist with the communication needs of the patient with an artificial airway. Mechanical ventilation may result in sleep deprivation and loss of touch with surroundings and reality, as well as the inability to talk. Provide the patient with an alternative means of communication. Orient the patient frequently to the environment and functions of the mechanical ventilator. Ensure that the patient receives adequate rest and sleep. Many facilities maintain a flow sheet to record ventilation patterns, ABGs, pertinent labs, fluid balance, weight, vital signs, and other clinical assessments. This is important for the collaborative care of the patient on the mechanical ventilator. And finally, change the ventilator circuitry per facility policy to prevent contamination of the lower airways. The next component of nursing care is to assist with the weaning process. For weaning to occur, the patient must have acceptable ABGs and an oxygen saturation with no evidence of acute pulmonary pathology. They must also be hemodynamically stable. And finally, the patient must be awake and cooperative and displays an optimal respiratory drive. Popular modes used for weaning include SIMV or pressure support. Once weaning is successful, extubate and provide an alternative means of oxygenation. Extubation is considered when tidal volume, vital capacity, and negative inspiratory pressure, which are pulmonary function test parameters, are normal. When these parameters are normal, it indicates strong respiratory muscle function. Now I would like to discuss ventilator alarms, but before I do so, I would like to show you the relationship between flow, pressure, and volume. Let's consider a patient who is ordered assist control with a rate of 14, a tidal volume of 500, an FiO2 of 50%, and a PEEP of 5. These three lines indicate flow, pressure, and volume. This baseline here will remain above 0 because of the PEEP of 5. When the patient takes a normal breath, you'll see the pressure drop and become negative. At this point, the vent will sense a negative pressure and a breath will be triggered. Pressure will then rise to a set level. Flow, on the other hand, will elevate to a set level, plateau, and then fall, while volume will incline to its set level. When the patient exhales, flow will drop below 0 and then elevate back to 0 like so. Pressure will drop to the baseline predetermined by PEEP, and volume will also decline. Now, the difference between a patient-initiated breath and a ventilator-initiated breath is a lack of the negative pressure drop. In assist control, you'll continue to get breaths because you've also set the rate. All other values will respond as if it were patient-initiated. So to recap, PEEP maintains this line above 0. This is a patient-initiated breath, and this is a vent-initiated breath. And here is your set tidal volume. Now, what would occur, for instance, if you had a sudden drop in compliance? The pressure will rise. This will show here as an elevated pressure. All other values will remain close to the same. At this point, you'll have a ventilator alarm sound. There are actually two different forms of pressure that you'll see in the pressure waveform. One is a peak pressure, and the other is a plateau pressure. The peak pressure is also known as the peak inspiratory pressure, or PIP, and refers to the resistance in the airways. The plateau pressure occurs when air hits and stops at the alveoli, and refers to the compliance of the lungs. To illustrate this, here is what peak pressure refers to, and here is what plateau pressure refers to. Here are two waveforms that kind of resemble what these two look like. A difference between peak inspiratory pressure and plateau of greater than 5 millimeters of mercury is defined as an elevated peak. So here are your different types of pressure alarms. A high pressure alarm is usually set to go off whenever the pressure is 10 to 15 centimeters of water above peak inspiratory pressure. A low pressure alarm is usually set to go off at 5 to 10 centimeters below peak inspiratory pressure. So here you have your peak pressure, and here is your plateau pressure. An elevated peak pressure can be caused by the following: bronchospasm or bronchoconstriction, secretions or mucus plugs, the ET tube or circuitry can be kinked, or the patient may be biting the tube, and finally asynchronous breathing, where the patient's breathing against the vent. A plateau pressure can be caused by the following: a pneumothorax, pulmonary edema, ARDS, pneumonia, congestive heart failure, pulmonary hemorrhage, or pleural effusion. Low pressure is generally due to the inability to build up airway pressure because of a disconnection or leak, but this can also be due to a change in compliance or resistance. Remember that the priority is ventilation and oxygenation of the patient. In alarm conditions that cannot be immediately corrected, disconnect the patient from the mechanical ventilator and manually ventilate with a resuscitation bag. There should always be an ambu bag at the bedside. In general, when responding to alarms, you want to respond immediately, note which alarm is sounding, look at the patient, the heart monitor, the oxygen saturation, check your airway pressures, and troubleshoot the system. Briefly, I'll show you how ventilator adjustments are made. So looking at the values, rate, tidal volume, FiO2, and PEEP, your rate and tidal volume adjust CO2, and your FiO2 and PEEP adjust oxygen. Adjustments made to the ventilator are based on the ABG values. If you have a low PO2, you want to increase the FiO2. If you have a high PO2, you want to decrease the FiO2. In the presence of a low PCO2 and a high pH, you want to decrease the rate or tidal volume. And finally, in the presence of a high PCO2 and a low pH, you want to increase the rate or tidal volume. When documenting your assessment of the patient on the mechanical ventilator, you need to document the following. Note the ET tube size, the side of the mouth, and where it is taped in centimeters. Discuss the condition of the skin at the ET tube site and condition of the oral mucosa. Note the ventilator mode. Document the rate and tidal volume, and here it's important to note both the set and spontaneous rate and tidal volume. Note the FiO2, the oxygen saturation, and PEEP. Some professionals even include the peak inspiratory pressure. Document the symmetry or asymmetry of chest rise and fall. An unequal chest rise and fall may indicate right mainstem intubation. Discuss accessory muscle involvement, retractions, and bulging. When palpating the patient's chest, note whether or not you feel crepitus. This can be indicative of subcutaneous emphysema. Document your percussion findings, as well as your lung sounds. And finally, be sure to note the intubation date.